welcome to Slide Review. This week we are going back to our GI to finish out with some benign entities involving the colon, appendix, and I may have even thrown in a few lesions involving the anus as well. So as always, we start with our standard disclaimer, and as always, if you have any questions about this or anything else, please leave them either in the comments. We have both of the Twitter handles that we use below, so that you can use either of those. And let's get started. So, infectious, inflammatory, and overall benign lesions. So starting with the appendix, this is case 1. So the first thing we notice is that while we do have a lumen here, and you can see that this is a cross-section of the appendix, this one looks somewhat obliterated, and what we have here is a bit of a buzzword, but all along here we have what's known as the pearls on a string phenomenon. And one of the things that even at this low power that's jumping out at me are these sorts of areas. And you can see some of them here closer to the luminal surface. So how about we just go in and take a look at those. And what we see, if anyone knows what this is, but these are granulomatous formations. Okay, so they are made up of, so what these are made up of is we have these very epithelioid histiocytes, and they're surrounded by lymphocytes. Okay. If you go to your mucosa, since there's only a little bit of it, what we see is that it's synonymous with our epithelium that we see within the colon, and it's mostly lymphoplasmacytic underneath the epithelium, and the epithelium itself is a little beat up, right? It's a little ragged looking, with some of the nuclei looking a little more reactive, but generally it's not scary. Like, we're not seeing anything that looks like an adenoma, and this does not have the overall appearance of, say, like an acute appendicitis. Now, this area is the area that looks more obliterated. So we see, like, here's some fibrin deposition, but again, we have like these granulomatous formations or lymphoid proliferations as well. And then when they talk about the pearls on a string, what they mean are like these areas of lymphocytic proliferations that just kind of look like beads. And then you have these areas that are thinned out in between. So you have like a bead thinned out, here's another bead. And this is even more prominent for lymphocytic. Okay, and that's about what I wanted to show you. This piece has some more pretty good granuloma formations, like here. You can see like these guys here. And we also have some areas that look a little more fibrotic. But okay, so what is this? This is granulomatous appendicitis. So it's found in about 2% of the appendectomies that we get. So appendectomies are relatively common GI specimens, so it's not uncommon to see this. And most patients actually will be asymptomatic, but if they have an underlying acute appendicitis or perforation or anything like that, you would expect the symptoms to be similar to that. The granulomas themselves don't really elicit their own symptomatology. And even grossly, they can be unremarkable, or they may have a thickened wall, and the mesenteric lymph nodes may appear enlarged, which makes sense. This is inflammatory, it's reactive, and as we saw, you're going to have clusters or groups of these epithelioid histiocytes. So epithelioid histiocytes, you may or may not see casein necrosis. Our case, I didn't really appreciate casein necrosis. and they have this rim of lymphocytes, or even, I think, a few scattered giant cells in our case, and it can be either focal or transmural, and often only your appendix is involved. So that's good to know that, you know, if you have an appendectomy that comes through and it has this granulomatous appendicitis, it's likely only involving the appendix. You can see a chronic colitis-like pattern, and what that means is that we have this basal lymphoplasmacytosis, so basal meaning underneath your mucosa. You may have cryptitis, you may have crypt disarray, but remember, because this is also lymphoid tissue, the lymphoid tissue itself can induce like a pseudo disarray where it's just kind of pushing everything out of the way, but what you have in between everything is the lymphoid tissue. It's not because of dysplasia. This is often seen with interval appendectomies, and interval appendectomy means that the patient was treated with antibiotics, so they were trying to cool down the lesion. That's what they'll commonly refer to it as, is cooling it down. And then what happens with those is you start seeing this xanthogranulomatous inflammation. So those epithelioid histiocytes become more foamy, more frothy looking, like we've seen in many other lesions before. This can also occur due to foreign material, and if there's foreign material present, it will polarize. So if you have granulomatous appendicitis, you must stain for microorganisms. So whether this is GMS, Warth and Starry, or worthless Starry stain, an AFB, etc., you should stain for those kind of things because you want to make sure that's not due to some organism, in which case that's how you would treat this patient. Your differential obviously comes down to, is it an infection, or is this actually inflammatory bowel disease, in particular Crohn's, that is involving the appendix? Now remember, you can have ulcerative colitis involving the appendix as well, but we like to refer to Crohn's as having the granulomas, even though in the end they both can have granulomas. So treatment, excision, or antibiotics and excision, but guess what? A lot of these occur with appendectomies, so they've already taken the appendix out, so then it's determining what is the actual cause so that they can ensure that they don't need to do additional treatment. And excellent prognosis overall. So these guys look a little more foamy, so maybe this was an interval appendectomy, in which case we have more of like a xanthogranulomatous pattern. And here we're seeing like a giant cell, so that's your granulomatous appendicitis. This is case 2. And what we see is that maybe at low power it looks very similar to our previous case. We have a lot of blue going on here. Looks like a lot of like lymphoid proliferation. I'm not going to be around the bush too much with this. Your pathology actually is right here, and maybe you can kind of make it out, these pink things within the lumen. So let's zoom in on those. And what we notice here is that we have this relatively thick eosinophilic cuticle. We start seeing some internal organs. If we go over here, you can see somewhat of a different view of it. Again, this really thick cuticle, internal organs. This is some food particles or fecal material here, so don't let that confuse you. So I don't know if anyone's on the line yet and knows what this is. Let's see if we can see any more parts. It's kind of just more material. And then if we go up here, we can see that this is lymphoid tissue, but it doesn't look as prominent as our previous case. Like, sure, there may be more blue, but it's really well organized. And if we go in, we're going to see more of like a mixed population in here. Okay, yeah, so this is our pathology, and I'm not hearing anyone. I'm not seeing anything pop up in the chat, and that's okay. So what this is that this is pinworm, or Enterobius vermicularis. There we go. Maybe that's a nova. pinworm really loves to go to the appendix. I'm not really appreciating much more, so I think that first area maybe was the best. Like foreign material, fecal matter. Yeah. So these are ova. So what you can appreciate with these is that they kind of have that same look as the cuticle in the adult worm. And they're somewhat ovoid, but you can appreciate how this side looks a little more flat. Like they kind of almost look like for those who had like Nickelodeon growing up, like Hey Arnold, and they always tease him and call him like a football head in the cartoon, kind of this same shape, or Stewie Griffin from like Family Guy would also be another example, but that's what the ova look like. So pinworm, threadworm, enterobiasis, X, oxyuriasis. Okay. So the interesting thing about pinworms is that humans are the only natural host, and they're present in approximately 13% of appendix resections worldwide. This number is a lot lower here in the United States, but it's something to note, like if you have patients who have been doing a lot of traveling, or they come from a more endemic region, you'd want to consider these kind of things. They most commonly affect younger children. However, they can affect all ages, okay? Most patients are asymptomatic to this, and these could be an incidental finding, but one of the most common things that we see is anogenital pruritus, and particularly at night. And the reason for this is that that's when the worms are coming out to lay their eggs. And so we do the overnight Scotch tape test, or the tape test, which is where you put tape over the perianal region and over top of the anus itself, and you will actually like catch the eggs and maybe even the worms on the tape. That can be taken in and tested. So how this occurs is that the ova hatch in your duodenum, and then the larvae eventually become adults, and they go down to your distal ileum, your cecum, and your appendix, and that's where they mate. And the male actually will die post-copulation. So remember how I said if you're capturing worms on the Scotch tape test, those are going to be female worms, okay? And they're much larger than their male counterparts, and the females are the ones that will travel down to the anus, and that's where they lay their eggs. Okay, and these worms can cause so much of a problem. They can actually cause obstruction of the appendiceal lumen, okay? So you can appreciate why that would become symptomatic for the patient and induce like appendicitis. So here grossly, these worms are inside the appendiceal lumen, and here we have a cross-section of one of those worms. So here they have ova inside the female, and you can see the lateral ala, which we will get into, and this is within the lumen of the appendix. As we were going over, the ova themselves are these bilayered shells. They're refractile, and they're generally about 50 by 20 microns with that flattened side, that sort of ovoid football shape type ova. The worms themselves have this very thick cuticle, and you will see the lateral ala or lateral spikes, okay? And you can easily see their internal organs. The interesting thing to note about pinworms is that even if they are invasive, so even if you have worms within the appendiceal wall or the intestinal wall, there will be minimal to no inflammation and very rarely associated with granulomas. Again, we go back to our testing. So our IHC really stands for like our testing, not just our immunohistochemistry, but your Scotch tape test is far more sensitive than even a stool culture, so that's the best test to do. Your differential includes other inflammatory disorders as well as anal fissures. And again, the anal fissure is related to more like the itching in the perianal area. For treatments, they like to give antiparasitics. Obviously, this is a parasite. So mebendazole, albendazole, Priantel, Pamoate, those are all great things to give for this. And the prognosis overall is excellent. So pinworm, Enterobius vermicularis. And from here, we're going to spend the bulk of our talk on the colon, looking at different infectious and inflammatory lesions. So this is case 3. We have a lot of cross sections of the same piece, and what we notice is, hey, someone left us a little love mark. There is an ink spot here, which is fine. There's nothing wrong with that. So we're just going to go in and take a look at this piece. And what we see is that, yes, we have colonic mucosa, a large amount of plasma cells, and how can I tell they're plasma cells? Like centric nuclei. We have this perinuclear Hoff that isn't impaired in all of them, and they have relatively moderate eosinophilic cytoplasm. Here we have an eosinophil. You can always pick those out. Generally not a whole heck of a lot going on in this piece. It looks like maybe we've got some lymphocytes, so maybe there was some sort of like a chronic colitis going on here. And it looks like we have a relatively increased amount of collagen deposition underneath the mucosa. So here's our mucosa, and then we start seeing collagen underneath, which is something to keep in mind for something else we will see. And here's kind of what I'm looking for in this lesion. So I'm starting to see like more of this sort of ballooning type degeneration within the mucosa surface. It looks like maybe we have some very focal areas of active colitis, but I'm not totally convinced. And again, this very prominent collagen deposition. Start seeing some cells that look somewhat signet ring-like. Like this is a good example where you can see that nucleus is pushed right to the edge, and then your cytoplasm here, it makes it very round, so it looks like a ring. This piece is detached, but kind of the same thing in it. Like we're starting to see more of that ballooning degeneration. Okay. So it's just this last piece. And again, we're starting to see a little more ballooning degeneration, this collagen deposition that's kind of entrapping inflammatory cells. And we're going to pick up speed a little bit after the mouse hiccup. So this is pseudomembranous colitis, and pseudomembranous colitis is very commonly associated with Clostridium difficile, and some of the features that we saw could be attributed to Clostridium difficile. So I'm by no means saying that this is definite Clostridium difficile infection, but it's the most likely thing just based off of a single slide. Okay, so C. diff, most common nosocomial GI infection, and this is related to toxin A, which is enterotoxic. So basically it makes the cells in the gut all weepy, so we have a lot of fluid secretion out there, and there's also this toxin B that's less toxic. And what you should know is there's this NAP1 ribotype 27 with mutated TCDC, and what that relates to this specific strain of C. diff has increased toxins A and B. So our elderly and debilitated, so anyone who's like bedridden or at increased risk, and so C. diff itself can cause colitis, that's what I'm saying there, and most often it will cause a pseudomembranous colitis. This is often also related to recent antibiotic use, and usually oral antibiotic use, okay, not IV, There can be chronic inflammatory bowel disease or things like indwelling tubes. And this is very watery diarrhea, or at least at first it's watery. You can get bloody diarrhea later on. They may have fever or abdominal pain, and generally they'll have a leukocytosis. This can be diffuse, segmental, or even patchy involvement of the colon, and you'll see these yellow-white exudates. They almost kind of look like corn kernels on top of the mucosal surface, or you can see pseudomembranes themselves, which are kind of more dull and gray. And the underlying mucosa, if you were to take these off, is going to be extremely friable and erythematous. So what we were seeing and trying to appreciate on the mucosal surface was that degenerating, ballooning, signet ring-like features. You can see intercrypt necrosis. Didn't really appreciate that in this case. You may or may not see pseudomembranous exudate. If it is present, it tends to heap, so it looks like a volcano, or it can be domed or mushroom-shaped. Other things that you can see that tend to be relatively early, nonspecific, or focal cryptitis, which I think our case did have. The stroma was partially hyalinized, but I think it ties into our next case, well, 2 cases now, not next case, as well as some crypt abscesses. So for assays, there's lots of things that you can do. Your cytotoxin and nucleic acid amplification are probably your best tests. Okay, we learned about latex agglutination, but it's really not a good test for C. diff. You want to compare it to other infections, so these are the most common things to be confused with C. diff. Ischemic colitis is in there, signet ring carcinoma, of course, because we have the signet ring type degeneration, as well as collagenous colitis with pseudomembrane. So I think that even though we had a pseudomembranous colitis, our case had some features of collagenous colitis as well. One of the things that you want to keep in mind too is a lot of these entities can be mixed, they can be on top of each other. So when we get into, because we will get into things like our inflammatory bowel diseases and stuff like that, remember, these things don't always occur in isolation, so you always want to keep your mind open with those. Treatment for C. diff is typically Flagyl or retronidazole. They can also use vancomycin. And the fecal microbiota transplant is actually really effective. So that's something else that they can do. And for prognosis, about half your cases are going to be recurrent, even with optimal treatment. So you do everything you're supposed to do, and the patients can still recur. And there can be severe complications resulting in death in about 7% of cases. But remember, this tends to affect the elderly, the severely debilitated. So these are patients who may not already have a really good baseline. What we're showing in our pictures is here we have like some crypts missing. This is showing again that signet ring degeneration. It's a little more basophilic than our case, but I think this is partly due to their staining. Here what they're showing is lots of edema. It looks like there may also be some acute inflammation, so maybe some pseudomembranes. And here the mucosa is really reactive looking. So this is case 4. And again, these are all like the same cut. So we're just going to go straight in the middle. We have colonic mucosa, and what we're appreciating is like there's increased inflammation within the lamina propria. It actually looks like maybe it's more lymphoplasmacytic, but let's see. A little bit. We have some neutrophils. You can see the ants, again, plasma cells. So we have ants, we have neutrophils, we have plasma cells. More neutrophils. It's kind of hard to make out if we're really seeing like any cryptitis. Maybe. so at least like something's more reactive. That's definitely a mitotic figure there, and that could be a lymphocyte, it could be a neutrophil. Nothing super impressive yet. So it's hard with these tiny little biopsies too. More neutrophils. And that's kind of what we're seeing is this lymphoplasmacytic background, scattered neutrophils. Oh, there's some neutrophils. Okay, so we do have at least some focal active colitis. It's kind of hard to tell though, do we really have surface? This just kind of looks like it was pulled apart. But definitely a little bit of cryptitis. And our surface just kind of looks reactive. I'm not appreciating like abscess formation or anything like that. This could be crypt abscess. I find all these lesions difficult because they all have very similar characteristics, so it is subtle findings. But okay, so we have this very relatively mild type colitis. We have definitely have edema, but it could be artifactual, but this looks edematous in here. There's definite spacing. The surface epithelium looks more reactive than anything, but we don't have a lot of it. So, oops, you always want to be careful when you don't have a lot of anything to avoid saying too much. This, again, looks a little more reactive, like maybe we have some changes going on in there, but not a lot there. But these findings are actually consistent with Campylobacter. And I think the pictures from ExpertPath are a little better examples. But again, these cases are hard. If everything was easy, then maybe we wouldn't have a job. So, okay, but Campylobacter is the most common stool isolate. So remember, C. diff is something that's normally in your GI tract, whereas Campylobacter isn't. But the most common stool isolate in the US and the most common cause of diarrhea worldwide. Okay, it's foodborne or it can be contracted directly from animals. C. jejuni is the most common, and that is foodborne, but you also want to pay attention to C. fetus because of its association with immunocompromised patients. And again, our infants or very young adults, anyone who's HIV positive, that's who you want to be focusing on for CAMPy. There is autoimmune disease association with this as well. The patients will complain about this really watery diarrhea. There may or may not be blood in it or leukocytes, okay, so you could have blood or white cells in it. And again, they may have fever, abdominal cramping, nausea, vomiting, and general malaise or weakness. And if they have a history of ulcerative colitis, this actually could cause a flare within them. Okay, so here we can see how sometimes it can be hemorrhagic, and here we can appreciate more of like the distortion picture. Okay, so we can either have segmental or diffuse colitis. The mucosa itself will be friable, erythematous, and hemorrhagic, and you may or may not see ulcers or exudate on the mucosa surface, but it also can appear grossly normal. So that's why when they're doing upper and lower GI, they may take biopsies of what looks to be normal, and it could still have pathology associated with it. So you always want to correlate what you're seeing under the scope with what they were seeing on endoscopy. Microscopically, this looks very similar to acute, infectious, or limited colitis. So your epithelium relatively will be damaged. You may have like cryptitis, which we're seeing some cryptitis looks like in here. You may have abscesses, neutrophils in the lamina propria, so that's good. We're seeing that. We saw one possible crypt abscess. There will be edema. You may or may not see granulomas, but if they are there, they will be loose, okay? They won't be very well defined. You can see mucosal hemorrhage with these, and you can see some mild crypt distortion or crypt loss, okay? But I stress mild, okay? You shouldn't see like complete crypt distortion and dysplasia associated with this, okay? Your stool culture is actually your best test for CAMPy. There's lots of other things that you can do, including like a multiplex PCR, but your stool culture is the best test. Your differential, again, other infections. So you see how these things kind of just keep cropping up. We'd also want to differentiate it from inflammatory bowel disease, so whether that's Crohn or ulcerative colitis. Treatment for this is generally supportive, but if a patient is immunocompromised or has really severe disseminated disease, you may consider antibiotic use. And often, infection with Campylobacter, even though it is the most common stool isolate and it is the most common cause of diarrhea worldwide, is self-limited. So usually within a week, and they'll have complete resolution of all their symptoms within about 2 weeks. However, you want to consider relapse in those immunocompromised patients. So there's your Campylobacter. This is case 5. And really the pathology is all of this stuff here. So this area looks more normal even at low power. We can see how our crypts are coming down, they're touching muscularis mucosae, and that's what we like them to do. And then we start getting into this area where there's ulceration. Okay, so we see, how far can I zoom in? Yay! So we see all these little ants, okay, all these neutrophils. So this is, and there's all these neutrophils, and we're not really appreciating that epithelial layer anymore. So this is at least erosion, if not ulceration, okay? And we have all this hemorrhage that's up in our superficial, like lamina propria and submucosal surface. I'm trying to see how far this goes. We're starting to get into some areas where it looks like maybe it just wasn't maybe fixed well, but the hemorrhage is quite prominent. We have some vessels here. And this one almost looks like it was completely thrombosed. And here we have inflammatory cells. Here's a vessel. Here's a bigger vessel, inflammatory vessel. So there is this vasculitis. This is probably even better. See all these little ants associated with the vessels. So when you have all these things and you put them together, I don't think we have much epithelium to look for the other things, or at least much intact epithelium. This is like bacteria, which just means that's been sitting for a bit. Okay, but we have all these things going on. Oh, maybe down here. Let's see. No, not really. So what I was looking for was things like crypt abscess, and this again is just kind of falling apart, so you don't really want to say too much about that. But this is ischemic colitis. So it's found in middle-aged to elderly adults, so greater than 50 years old. And you can also see it in infants. And in infants, we call it, it's associated with necrotizing enterocolitis. It also occurs in a small percentage of renal transplant patients. And there's a whole list and a whole schwack of literature listing numerous causes of ischemic colitis. And the list is very lengthy. By no means do I think that what I put here is a complete list. It's just kind of to give you an idea of what's going on. So symptomatically, they'll have sudden onset of abdominal pain and GI bleeding. So this can look either like petechiae, or you can have full ulceration depending on how extensive it is, how long it's been going on, and where it really likes to go is between the splenic flexure, in the area of the splenic flexure of the transverse colon, and that's because that's a watershed area. And a watershed area means that while it's perfused, it doesn't do well if like those small arteries have either they're thrombosed or they are constricted because it can't quite reach all the tissue. So you have these areas in the colon and also in areas like the brain that have this watershed these watershed areas. So again, the petechial hemorrhage, it can be edematous, it can be really friable. Here we have these longitudinal ulcerations, and you may or may not even see blood or dark mucus within the lumen of the GI tract. Microscopically, the findings will either be on the surface, within the wall of the GI tract, which is related to hypoperfusion, or transmural, which means all the way through the wall. And when that happens, you know that there's a major vessel involved with the pathology. If it is segmental or patchy, then you'd want to consider things like, is this a chronic ischemia rather than an acute event? What you're going to see are things like necrotizing phlebitis. So again, these vascular insults. You can see thrombi. They'll be hyalinized within small vessels. So I think we saw one in our case. You can see necrosis or ulceration, granulation tissue, and we did appreciate that. It can extend into the submucosa, and it can involve even the smooth muscle, the muscularis mucosa. So that's why knowing where all those boundaries are is really important. You will see hemorrhage or hemosiderin pigment deposits, as well as edema within the lamina propria. Excuse me. And you may or may not see crypt abscesses. So that's what I was hunting for at the end. If you do see crypt abscesses, it will spare the deep portion of the crypt, okay? So the abscess will be in the mid to superficial aspect of the crypt. Inflammation is very mild and present. Again, a lot of what we were seeing was involved with that ulceration, that granulation tissue, but you can see exudate or fibrin on the surface. And again, transmural fibrosis will be suggestive of a later lesion, which means so it's had time to basically scar over and lay down all that collagen, so it's been there for quite a while. Your differential includes things like inflammatory bowel disease, so again, Crohn's or ulcerative colitis, as well as EHEC, again, a hemorrhagic colitis, so you'd want to think about those kind of things. Treatment is generally supportive. If they do surgery, it's usually for things like, was there a perforation? Is there generalized peritonitis? Is there transmural infarction? Those kinds of things. And it's typically a segmental excision as well. There's a lot of complications that can be associated with this, but generally the patients will do well once they've dealt with whatever insult is there. So getting rid of, if they have to do a segmental colectomy, the patients generally will do well, as long as they've gotten clear margins at that point. Okay, so all these pictures are just kind of showing different things of ulceration. So that's why the tag is below. Okay, now this is a little different. This is case 6, and what I'm showing you here is non-H&E. So hopefully, without seeing the video, if you're seeing the slides, you're able to appreciate that. So what this actually is a picroserous red. In our institution, we use trichrome, Mason's trichrome, a lot more common. This is a picroserous red, and what it's really good at picking up on is collagen. And as the name suggests, it turns red. So just to orient you, rotate this a little bit. So here we have the mucosal surface of the GI tract. Our crypts are coming down, and here we have muscularis mucosae. What we notice though is underneath the epithelium you have this increased deposition of collagen. Okay, this bright red deposition. And there's some areas where it's even thicker. And it's not a very regular band, okay? Like in some areas it looks a little thinner, in some areas it's thicker. Here we're upside down, so your epithelium is down here. But you can see how it's kind of irregular. This is a lot of collagen immediately underneath the epithelium. And again, just recapitulated over here. So what I was trying to show with this is a phenomenon known as collagenous colitis. And even though we touched on it very briefly in our pseudomembranous case, I thought this was a very nice example. A, to show a stain that, at least at our institution, we don't see very often, if ever, and just to really drive home that collagen deposition. So collagenous colitis is one part of microscopic colitis. It has a relatively low incidence, but the incidence actually increases with age, and there's a female predominance that ranges anywhere from 3 to 1 to 9 to 1. This is more common in both North America as well as Northern Europe, and we don't really know exactly what causes this. There are probably at least a dozen or more theories about how this occurs, and the patients will complain of this really chronic, relapsing, recurrent, watery, non-bloody diarrhea, okay? And that is extremely important to have in the history. Is the patient having diarrhea? Are they, like, what medications are they on? All those kinds of things. This really likes to occur in and involve the right colon or the transverse colon, but you can see it as well in the stomach and in the small intestine. Grossly, it's going to appear pretty much normal. You may have some erythema or edema. There may be some abnormal vascular patterns. Very rarely, you'll see pseudomembranes. So remember, collagenous colitis with pseudomembranes was in our differential for pseudomembranous colitis when we were looking at things like C. diff. So I think that's a very important thing to know as well. The other thing that you can see are what are known as these cat scratch colon, where they have these very long longitudinal mucosal tears. And this is actually related to insufflation. Insufflation, is when they use air to blow up the colon like a balloon, essentially, when they're doing the endoscopy. But because you have these tears and it's related to blowing up the colon, this can lead to perforation in a small percentage of patients. Okay, so what we have is increased intraepithelial lymphocytes, which we've gone over several times. You want to think about things like celiac disease, or we were talking about increased IELs in the small bowel lecture, which is GI2. And this is a very thick band. You don't have to measure the band to make sure it's at least 10 microns thick, but it should be at least 10 microns thick. But basically, it's going to be very irregular. Like here, you can see how it has that sort of irregular pattern. You have some inflammatory cells that are entrapped within it, not the crypts, but inflammatory cells. It's kind of like pushing away the crypts. And it likes to have a detached epithelium. What it means by that is you're going to have the surface collagen that's thickened, and then your epithelium is just going to kind of be hanging out above it, okay? You can see things like eosinophils in the lamina propria. You may or may not see mast cells. You should also have a lot of lymphocytes and plasma cells. So here we can see there's a lot of plasma cells in that case. And there are, of course, variants. So here's an example of the trichrome, just kind of give you the difference. So in trichrome, you're looking for blue. on the Pico series red, and you're looking for the bright red. You can also do tenacin IHC, as it's mostly, as the collagen deposition, the collagen band, is mostly type 4 collagen as well as tenacin. There is some data to suggest that maybe we need to look at HLA. However, everything that they have is inconclusive, even though they have these well-known familiar clusters. So we're still not quite sure what causes all this. Your differential is fairly extensive, and your treatment for this is mostly immunosuppression. So corticosteroids, immunomodulators. If they are refractory or it's a severe case, then they might want to look at surgery. And prognosis for these patients is generally benign, and they have complete remission in greater than 50%. Like in some instances, I think it approaches closer to like 80 or 90%. But there can be complications associated to all that watery diarrhea. So you want to think about electrolyte imbalances, dehydration, all those kind of things, which can also be very serious for patients. So that's your collagenous colitis. A7. And we're just going to rotate this one around too. So it's a little easier to orient. So again, we have surface up here. You have your muscularis mucosae. This is your muscularis propria, and then we're looking into your soft tissue and maybe some serosa down there. Okay, first thing we see is that maybe this stuff looks more like normal bowel. But all this stuff, this looks like maybe it's ulcerated. We have inflammatory, or what looks inflammatory because it's so blue, going down into the muscularis propria. And okay, so let's just start over here. And what we see is that generally, yes. Okay, this is massively inflamed. We have lots of eosinophils. Are there eosinophils? I think so. Everything's kind of red as soon as I went on higher power. Very, very high percentage of plasma cells. Here's our muscularis mucosa, so you can appreciate how these plasma cells are coming all the way down to the muscularis mucosae, and they are pushing up on these crypts, okay? So this is what's known as basal lymphoplasmacytosis, and that's what they mean by that, is that it's not allowing those crypts to go all the way down to the muscularis mucosae. So it's inducing a type of crypt distortion by doing that, okay? Let's go into that area, though, that looked a little more eroded. See what we can see. So we definitely have ulcer, right? Here's our, we have lots of little ants in here. This kind of has like a mixed inflammation type picture. We have fibrin in there. Again, just so many plasma cells. They're just really prolific. Something else that we can see, again, inflammation. And what you want to pay attention to with the inflammation, like we're in the colon. So what we have is like this transmural inflammatory process that's going on. And then this area kind of has a fibrotic look to it. We're seeing like a lot more collagen fibers going on through here, so that's another potential feature that we'd be looking for. And then something that you can see quite a bit, but I'm not sure that I'm really appreciating it. Maybe. It's hard to tell that this stuff is kind of falling apart. is vascular injury associated with this lesion. Kicked it out, no. Okay, so we have some crypt distortion. This is a normal vessel. Okay, this is a perforating vessel, so that's fine. That's not abnormal at all. We have this ulcerated lesion that has transmural inflammation. I don't think I'm seeing granulomas, but you don't necessarily have to have them. You can though. We do have vascular injury. So what this is a case of Crohn's disease, or inflammatory bowel disease, Crohn's disease. But it, even though it's ulcerated and everything, not really appreciating a lot of activity in the crypts. But again, we have these huge areas of erosion and ulceration, so maybe that's also part of the reason why we're not seeing a lot there. Well, there is some activity. So we have neutrophils here, so that's good. We have our cryptitis. Can't tell if that's crypt abscess. Yeah, maybe. Why is it so pink here? Oh well. But, okay, so this is a Crohn case. So Crohn's is 0.01% of the general population, so thankfully it's not all that common. This tends to affect young adults between the ages of more like 10 to 30, even though I wrote 20 to 30, it's more like 10 to 30, because a quarter of them will be less than 18, and again, it affects females more than males. The triad of symptoms that is usually associated with Crohn's disease is diarrhea, abdominal pain, and weight loss. And the idea is that the etiology is likely related to sensitization of the GI tract. And we do see increased incidence with our Ashkenazi or Eastern European Jews, as well as the Welsh population. So you can see there's quite a significant increased risk of developing Crohn's disease if it is present in a first degree relative. However, when they did twin studies, there was incomplete penetrance, so that suggests that there's something else. It may be an environmental factor or something like that that's going on to elicit the Crohn's disease in a patient. Most of these cases involve the ileocolonic regions, so the ileum as well as the colon, but you can kind of see it everywhere. There's a large amount of literature on non-GI sites, and a quarter of patients will have an extra GI site. Ankylosing spondylitis is the most common, but I put as many of those as I could really find in the handout, so you can take a look at that to see some of the other associations. The mucosal surface will have this variety of either stress ulcers, fissures, cobblestone appearance, so kind of like something like that. Here's a stricture. You can have fistulas, and a lot of these showing strictures and fistulas. You can have fat creeping, so that's where the fat's kind of trying to protect this injured colon, so it's trying to wrap itself around any affected segment. And again, you can have fistulas. This can be to other organs, other segments of bowel. It can even be through the skin. And again, because Crohn's tends to have the skip lesions, you will have normal mucosa between these lesional areas. So as we talked about in your mucosa, you can have erosions or ulcerations. You should have this lymphoplasmacytosis with that basal lymphoplasmacytosis, keeping those crypts up from the muscularis mucosae. Cryptitis should be neutrophilic, and again, this can be patchy, so we didn't see a lot of it, but here's a good example of one of those, and this is probably related to this crypt blowing out. You can see inflammatory pseudopolyps, and these are basically relatively normal mucosa that's between these ulcerated areas. It can look regenerative in appearance, and it can be polypoid because of the granulation tissue that's associated with it, and there can also be edema as well as fibrosis. Again, submucosal fibrosis, neuromuscular hypertrophy, so expansion of smooth muscle. You can have areas that can look like neuromas or neurofibromas, and that transmural chronic inflammation. Other things you can see would be like panacell metaplasia, pyloric gland metaplasia, and panacell metaplasia usually more like the distal transverse colon and left colon, because it's actually not too uncommon to see on the right side colon and proximal transverse colon anyway. Crohn's is typically associated with these well-formed non-caseating or non-necrotizing granulomas. However, you can have focal caseating necrosis. When present, they will have giant cells with this lymphocytic rim. They may or may not be epithelioid or intracryptal, which means involving the crypt, so kind of like that. And they can be deep as well. You see increased incidence of this again. So as you're traveling towards the left side of the colon, the distal colon, like you would see an increase in panacell metaplasia, you can see increase in granulomas. These are often surrounding the vessels, and they can also involve lymph nodes. About 30 to 40% of lymph nodes will be involved by granulomas if present in Crohn's disease. And the last thing we mentioned was that vascular injury, so either thrombosis, granulomatous, or fibrinoid vasculitis, as well as lymphatic dilatation. I didn't really appreciate the dilation of lymphatics so much in our case, but it is a large piece to go through, so there may be some focal areas as well. So for tests, the two things that are most important to look at is your ASCA should be positive and your ANCA should be negative. This pattern is typically reversed in UC, so it's a good thing to keep in mind. Stool cultures will be negative, and a lot of these other things can be elevated as well, so it could clue clinicians into, hey, maybe we have a Crohn's case, we should do a scope. And the molecular, so the mutation that's known to be found in Crohn's is this NOD2 CARD15, and basically what that relates to is it keeps your NF-kappa B always on, so you get this overproduction of cytokines, which is a pro-inflammatory response, right? So we get this really ridiculous, over-the-top inflammatory response, but it's not really effective. Like you have like millions of these lymphocytes and plasma cells and eosinophils and everything else that's in your lamina propria, but they're kind of just focused on all the cytokines that are there, that are calling them there, rather than looking at, oh, the bacteria that's here, and we have a job to do. So then you get also this bacterial survival and bacterial overgrowth is a real possibility. So this NOD2, which maps to your IBD1 susceptibility locus, this is unique to Crohn's disease, okay? It's not found in ulcerative colitis, so that's something to keep in mind. This is just showing you transmural inflammation. Again, a lot of our lymphoplasmacytosis. This is panacell metaplasia. This is pyloric gland metaplasia here. And here looks like an ulcer, maybe a granuloma. Okay, again, huge list of differentials. Your history is important. What they saw on the scope is important. So you want to correlate all these different things. It's really a multidisciplinary team and approach that's required to treat these patients. They try to use either steroids, biologics, biologics, immunomodulators, they kind of just throw everything at this and see what sticks. And they try to reserve surgery for absolute needs, so perforation, obstruction, refractory to medical treatment. Because these patients are prone to fistulas, it is segmental, so you can't exactly remove a patient's entire GI tract, and they'll still have extra GI manifestations in a good portion of patients. So they try to manage what they can medically. Here, this is showing like a poorly formed granuloma. Recurrence, well, this is a chronic disease, unfortunately. Recurrence is extremely common. Almost all patients will recur within 10 years of diagnosis. There is an increased mortality associated with it. They have increased carcinoma, lymphoma, and because of all the hospitalizations and surgeries and everything else, they really have a decreased quality of life. So those are all things that you want to consider when you're looking at a patient who potentially has inflammatory bowel disease, making sure that you're showing the case to someone else to see what they think, and you're correlating with what your clinician's telling you. Some of the other things that we're looking at here, so this is one of those pseudopolyps. This is showing a fissure. So your fissures will always be sharp and knife-like. This is showing creeping fat here. Okay? This is case 8. And again, they left us some extremely helpful docs. So we're just going to take a look at those. Well, we can take a quick zip around all this. So at medium power, this looks relatively similar to what we saw in our previous case. Again, lymphoplasmacytic. Not seeing too much else. This is poorly laid, but maybe there's some increased fibrosis. Nothing that's incredibly striking yet, though. But what you start seeing is that, okay, so we have surface here. Unfortunately, I'm not seeing a lot of like muscularis mucosae that helps you really orient and figure out how much distortion, if any, is present. I think there is some distortion because all these donuts, these should all be like the same size. What we are seeing is panicell metaplasia, so you can always pick that out at low power. Start seeing them like here. But again, we don't know exactly where in the colon this is, so if this is right colon, this is a relatively normal finding. Okay, but not too much. So we're going to go, I got this piece too. So this again looks a little more lymphoplasmacytic, maybe some histiocytes, nothing that looks really good for granuloma. And unfortunately, not a lot of crypts in that case. Okay, so here, so the first thing I notice is that, again, we have different sizes and shapes of the crypts. Some of these are kind of branched, which GI crypts do. They kind of are like a tripod. Remember, we're looking at a 2D image of a 3D structure. So a little bit of branching is okay. But the different sizes and shapes are a little more concerning to me. Again, we have all this inflammation, and it looks like here we have muscularis mucosae, and we can see that these crypts are like nowhere near going down to where the muscle is, okay? Like here's some wispy muscularis mucosae maybe, and everything is way above that. So even though we don't have a large degree of inflammation like we saw in the previous case, this is still abnormal. Okay, so there is some crypt distortion related with that. If we're looking at our inflammation itself, what I'm seeing is that almost all of this is plasma cells. There's some scattered cells, like, you know, maybe some eosinophils, but it's almost all plasma cells. And considering this isn't like a extremely prominent inflammatory response like we saw in the previous case, this really stands out to me. Hey, look, there's a mitotic figure. It's in the base though, so that's fine. Don't worry about that. As far as activity, I think these are mostly lymphocytes. Maybe that's a neutrophil. This really is not all that impressive. So I think this has more of like a chronic colitis type picture, which makes sense because of the distortion, but does not look active to me. It looks relatively chronic. It looks like it's trying to mature at the surface. But again, I'm not seeing anything that is like slam dunk for dysplasia or anything like that. Those still look more like lymphocytes, I think. But okay, so this is very likely a treated case of ulcerative colitis, okay, because of this chronic colitis type pattern. Now you would have to correlate again with the clinical picture to figure out if this actually is a picture of UC or not. Similar to Crohn's, it's 0.01% of the general population. However, unlike Crohn's, we have 3 peaks where we see inflammatory bowel disease, and this is the early 20s, 40s, and 60s. Again, females more than males. Your symptoms are pretty much exactly the same as what you would expect to see. For Crohn's disease, we add in hematochezia into the mix, and there may be some fecal urgency or fever. Crohn's disease can go anywhere it wants, okay? Whereas ulcerative colitis likes to start in the distal rectum, sigmoid colon, right? So we're looking at left-sided disease, and then it extends proximally. It can involve the appendix, and rarely can involve the upper GI tract. It's also associated with non-GI pathologies, and similarly to Crohn's disease, you have your arthralgias in there, but primary sclerosing cholangitis is found comorbidly with ulcerative colitis. So if a patient has ulcerative colitis, 5% of them will have primary sclerosing cholangitis. If a patient has primary sclerosing cholangitis, 70% of those will have ulcerative colitis. So it kind of gives you a sense, if you see one, you should really be looking for the other. On endoscopy, you're going to see this continuous, not patchy, continuous mucosal inflammation. So if they're active, it's very erythematous. You have the ulcers, there can be oozing or blood within the lumen. Whereas when they're chronic, you get this very granular appearance. It smooths out, and by smoothing out, I mean you get the loss of those rugal folds. Okay, no more mucosal folds within the colon. You may not see pseudopolyps or inflammatory type polyps, and you can also see filiform polyps, which are old inflammatory polyps. Microscopically, we can see a combination of either active colitis, which would include things like cryptitis, crypt abscess, or ulcer and exudate, which is what we're seeing up here. So this is a crypt abscess. Our case looked more like chronic inflammation and repeated mucosal injury. So you get that lymphoplasmacytic inflammation in the lamina propria. So again, it's mostly plasma cells. You're going to have that basal appearance pushing up those crypts. And this is relatively characteristic of ulcerative colitis, that really predominant plasmacytic infiltrate. You will have architectural distortion with chronic colitis. So the crypts may be dilated or branched and also irregular in appearance. So again, they start having these appearances of like young children trying to draw animals and those kind of things. The crypts no longer reach down to the muscularis mucosae, again because those plasma cells are pushing them up, and you can see past cell metaplasia. And again, just to point out that this should be distal to the proximal transverse colon, because it's normal to find in the proximal colon, so the right colon and the proximal transverse. If you have inflammatory polyps or pseudopolyps, they will have inflamed mucosa, and pretty much what makes up the polypoid part, again, is that granulation tissue. Filiform polyps are old pseudopolyps, okay? So again, you have these elongated projections of relatively normal mucosa, might be somewhat reactive. You're not going to see active inflammation, because remember, these have been around for a while, but you will see ganglion cells that are clustered within the core of these polyps, okay? So that's something to keep in mind, because ganglion cells can be scary. We have a little bit here about low-grade versus high-grade dysplasia. Didn't really appreciate dysplasia in our case, but there wasn't a whole heck of a lot to work with either. I think what happened with ours is that there was some treatment effect, because the crypts themselves, even though there was distortion, it really looked quiet, so maybe some treatment effect there. Here, this looks like it's showing a loose granuloma, as well as, the rest of this looks more like lymphoplasmacytic maybe. Okay, so remember how I said ASCA and ANCA are important for Crohn's? Well, you have the reverse pattern ulcerative colitis, okay? As far as molecular, whereas it's the NOD2 mutation in Crohn's, there's known HLA haplotypes that are associated with Crohn's disease. So I wrote down the ones that are known to be associated with ulcerative colitis. And your differential, again, is it Crohn's? This indeterminate colitis isn't something that we like to use because it doesn't really have well-defined features. So it's pretty much like if you're stuck and you can't call it one thing or another, that's when you turn to indeterminate colitis, okay? But these other things you're far more likely to be able to fit something in there rather than just calling it indeterminate. Indeterminate also doesn't really help your clinician figure out what to do next. So remember, like, as much as we are diagnosticians, we also one of our roles is to help the clinician get to the next step. Like, what's the next thing we need for diagnosis? What's the next thing we need for prognosis or for treatment? So you always have to keep those things in the back of your mind. Again, treatment is going to be multidisciplinary. They try a whole bunch of things, some of them very similar to Crohn's disease. Again, that fecal transplant is a novel therapy that they've been trying to use with some success, as well as probiotics or antibiotics. If they want definitive treatment, they do a total proctocolectomy, as well as an ileopouch anastomosis. So this is where the patients will have that J pouch where they take the end segment of the ileum and they backtrack it on itself, so it gives that J shape, and then that will be there for some patients forever, but they try not to because it's relatively irritating when you have ileostomy. Like, it can really irritate the skin around the ostomy itself. Anyway, so ulcerative colitis is this chronic disease, again, like Crohn's, with this relapsing recurrent course, very high likelihood of having active disease if the patient has had active disease in the year prior. So basically, if you've had activity, you're more likely to have activity the following year, and it just kind of keeps going. There is risk of progression to either dysplasia or neoplasia, and this increases every year, but it increases far more each year following 10 years post-diagnosis. So you just want to think about, we have this condition that's constantly irritating the mucosa, but it's not perforating all the way through, so we're getting this injury or insult to the mucosa, and then we have this reparative change, and it goes back and forth, so that's a really good environment, or prime environment, for developing dysplasia and carcinoma. As well as they can get things like lymphoma and stuff like that, but carcinoma would be more common. Severe complications include things like toxic megacolon, and when that happens, the colonic wall gets stretched so thin that you can actually get neural necrosis, because it's simply not possible for the vessels to perfuse all that tissue, and then you can have perforation and all the complications associated with that. This top picture, so this is showing you filiform polyps, so remember these are old pseudopolyps. And this is showing you some more of that pan-cell metaplasia, just to kind of tune your eye into that. Okay? And I quickly put this together just to kind of give you an overview of some of the non-microscopic findings that are associated with either, just to kind of get you in the mindset of like what's the difference between Crohn and ulcerative colitis. Your handout also has a list of like the variants of Crohn's disease, because there's quite a few of those. And with that, we are going to move to our last case. And I think we have some slides that got mixed up here, but that's okay. So this is our last case. This is case 9. And I'm not going to be around the bush too much. So this is an anal lesion. You can see we have all these dilated vessels, colonic mucosa, squamous mucosa. So this is a hemorrhoid. Okay? And what we have here, so you have squamous all the way down, and then we have our transition here to rectal mucosa or colonic mucosa. Okay? So this is a mixed type or transitional hemorrhoid. And you can see here we just have these dilated vessels. They will have these papillary projections in them. But these are something that, even though the microscopy seems extremely intimidating when we go over the microscopy, these are instantly recognizable because of the overall low power feature. And typically your clinicians will know what they're looking at when they either they're doing a closed or open hemorrhoidectomy. I mean, if they do something like the elastic band ligation, you might not get anything at all. So, hemorrhoids, also known as piles, okay, estimated that 4 to 5% of the U.S. population has hemorrhoids, but about 40% of women pre and post pregnancy will have them. Okay. These can occur at any age, but they do increase with the age to a point. After about 60 years old, we see a flattening of that curve. And there's a slight female predominance. If the patient is young or middle-aged, it's far more likely that they're going to have external hemorrhoids than internal or mixed. Predisposing factors for this include things like older age, pregnancy, as we noted above, inadequate fiber, chronic constipation, straining, diarrhea, prolonged sitting, even things like pelvic lesions or tumors that are compressing the pelvic region. These can all lead to hemorrhoids. External hemorrhoids are usually asymptomatic unless they're thrombosed, in which case they are extremely painful and they do not bleed. Internal hemorrhoids, however, will cause discomfort with bowel movements. They may have symptoms of prolapse or soiling themselves or this mucus discharge. it can also be very pruritic. And these patients will have bright red blood, so not like hematochezia type bright red blood typically, but like on the toilet paper when they're wiping, or they might see it on the stool itself. Hemorrhoids usually do not cause changes in bowel habits, okay? So if you have a patient who's complaining of changes in bowel habits, that's usually more proximal, and it's usually more indicative of things that need to be investigated. So whether this patient due for a colonoscopy or C-scope, those kind of things, like something probably more insidious than simple hemorrhoids. Grossly, so your external hemorrhoids are hail from the inferior hemorrhoidal plexus, so down here on this beautiful schematic, and they are innervated by somatic nerve fibers, so that can make them painful. If thrombosed, they will be this blue-purple perianal lump or mass, like almost like this blueberry-like mass. Internal, however, come from your superior hemorrhoidal plexus. This is above the dentate line, and they're innervated by the visceral nerve fibers, so they're relatively painless, which I know sounds opposite to what we said here, but remember, like thrombosed hemorrhoids are extremely painful, and discomfort is not the same thing as pain. So those are things you want to keep in mind. And mixed just means it's kind of like crossing that dentate line, and here's your dentate line. So they have features of both. That's what happened to the slide. Okay, so we will move this so it's less confusing when you guys go and look at the slides. Okay, so hemorrhoids are dilated, thick-walled vessels. They will have that intravascular papillary epithelial hyperplasia. I'm trying to see if any of these really show that. Not so much. But these areas will be papillary projections that are covered by endothelium. So remember, that's a single layer of endothelium, and they're within a pre-existing vascular space. Okay, so you're not going to have things that look like new vessels. But they can be scary, okay, because they will be hypercellular. They may have some mild pleomorphism. I want to stress mild, because one of the things that you're going to compare this to is this an angiosarcoma? And remember, angiosarcoma has more than mild pleomorphism. If there are mitotic figures, they should be relatively low in percentage, and you should not have anastomoses between vascular spaces. So each vessel is on its own, and that also hones you in a little bit to these are pre-existing spaces. You will have stromal fibrosis, proliferation of the smooth muscles, as well as elastin. And what's something that is interesting to note is that elastin can also be used to help you highlight the veins and venules, which is, again, somewhat counterintuitive, because veins and venules normally don't have that inner elastin layer. So that's something that can help you out. Muscularis mucosae should be thickened, and it should also extend into your submucosa. Your mucosa may be ulcerated or inflamed. It kind of depends what's going on with the situation. And again, if the patient's really itchy and it's external, they could be excoriating and irritating that further. So your external, again, these are covered by squamous mucosa. This is perianal skin, and you may have redundant skin present if there's skin tags. So again, you can see acanthosis, basal cell hyperplasia, and again, mild atypia. So like, we're thinking things that look more mild atypia, like reactive type changes, those kind of things. Internal, however, should be covered by mucosal epithelium, by columnar epithelium or rectal mucosa, okay? So here you can see crypt hyperplasia. So instead of acanthosis, crypt hyperplasia, there can be some mild distortion, again, stromal proliferation, and you may or may not see squamous metaplasia. And mixed just honestly means that it's crossing that anorectal junction, okay? It's crossing that dentate line, and it will have features of both. So again, we can see these very large vessels here maybe they're trying to show some of the intravascular papillary epithelial hyperplasia, but it's not super clear. Your differential, okay, things like skin tags, so fibroepithelial polyps, which are in your handout, and a lot of these other things, because they're either vascular lesions or things like the fissures can also be itchy as well and have blood on toilet paper, as well as discomfort during bowel movements. So, treatment for external hemorrhoids, these can resolve spontaneously, and when they do, they will leave a skin tag. You can try diet, so increasing water, increasing fiber, stool softeners, sitz bath, and this works in almost all cases. They can also do things like excision, ligation, sclerotherapy. I believe there's phototherapy, all sorts of things that they can do for hemorrhoids. If they're doing excision, closed hemorrhoidectomy, which means that they suture up the area, is far more effective than an open hemorrhoidectomy, but both are acceptable. Complications related to hemorrhoids, ulcerations or fissures. Again, inflammation, you can get infarction or necrosis, thrombosis, strangulation. So again, think of, you have these polypoid lesions, there's a lot of things that could happen, a lot of trauma that could happen to them. So those are generally your complications with them. And with that, that's the end of the cases that we have for this week. So we have 15 cases from our GI colon and Appendix 1 waiting for you guys. And if you thought that the cases that we had in the lecture today were difficult, wait till you see these. These are difficult lesions. These are lesions that I definitely struggle with myself. So we'll go through those and we'll get another challenge case video put together so that we can hopefully learn a little something together. If you did like this video, please hit like. If you aren't subscribed to us, please hit subscribe. If you have any questions, comments, things you'd like to see, things that you don't want to see again, all those things, please let me know either in the comments underneath the video, or again, you can reach out to me on Twitter. And with that, we will see you next week for our last week of GI. We will be looking at the malignant counterparts to the colon and appendix, and we hope to see you then.